Picture this. You've just stepped into the shoes of a young doctor arriving at the bedside during a totally chaotic emergency. Alarms are absolutely blaring. The nurses, they're all looking right at you. Immediate, decisive action is literally the only thing standing between life and death for the patient in front of you. So what's your very first move?
Well, welcome to this explainer. Today we're going to take all that overwhelming, adrenaline-fueled chaos of a medical emergency and transform it into a clear, structured, evidence-based mental toolbox. Whether you're a med student prepping for your very first clinical rotations or you're a young doctor who just wants to sharpen up those resuscitation skills, you are in the right place.
Okay, here is our clinical roadmap for today's explainer. We're covering mastering the code blue, the cardiac arrest algorithm, tachycardia and bradycardia pathways, the famous H's and T's, and finally the crucial 2025 guideline updates. Let's jump right in. Starting off with Section 1, Mastering the Code Blue.
Look, the absolute foundation of any successful code isn't some magic drug. It's high-quality teamwork and basic life support mechanics. You can have all the advanced medications and electricity in the world, but they mean absolutely nothing, and I mean nothing, without high-quality compressions. We're talking 100 to 120 beats per minute, going at least 2 inches deep, and you've got to let that chest completely recoil. Plus, you literally have to limit any interruptions to less than 10 seconds. And beyond the physical mechanics, your team needs crystal clear roles. Team leader, compressor, airway, medications, and closed-loop communication, completely non-negotiable. If the leader says, push 1 milligram of epinephrine, the medication nurse replies, pushing 1 milligram of epinephrine now, and then confirms when it's in. That kind of mutual respect and clear feedback, that's what actually saves lives.
All right, moving on to Section 2, the cardiac arrest algorithm. This is where your very first, most critical clinical decision has to be made in a matter of seconds. When you glance up at that monitor, you must immediately spot the difference between an organized rhythm and a chaotic, jagged mess. That chaotic rhythm, that's ventricular fibrillation, or VFib, and recognizing that difference instantly dictates your entire treatment pathway.
It all comes down to 2 distinct paths. If the rhythm is shockable, like VFib or pulseless ventricular tachycardia, your immediate, absolute priority is early defibrillation paired with CPR. You clear the patient, you deliver electricity, and you reset that chaotic heart. But if it's non-shockable, like asystole or pulseless electrical activity, PEA, defibrillation is completely useless. Do not shock them. Instead, you stay on the chest, focus entirely on continuous, high-quality CPR, and get epinephrine into their system right away.
So how does this build your pharmacological toolkit? Well, during a pulseless arrest, you're going to be expected to call out exact medication sequences. Epinephrine is your absolute workhorse here, 1 milligram every 3 to 5 minutes. Now, for refractory shockable rhythms, you'll reach for an antiarrhythmic. Amiodarone is the standard go-to. That's an initial 300 milligram bolus, followed by a 150 milligram dose, or alternatively, lidocaine is fully supported by the guidelines, starting at 1 to 1.5 milligrams per kilogram. Seriously, commit these numbers to memory so you don't freeze up when the entire room is looking to you for the order.
Now, let's shift gears in Section 3, tachycardia and bradycardia algorithms. We are stepping away from pulseless cardiac arrest for a minute to look at patients who do still have a pulse, but they're crashing fast due to dangerously slow or dangerously fast heart rates. And here is the ultimate fork in the road for both algorithms. Before you even look at the exact heart rate, you have to ask yourself, is my patient stable or unstable? A stable patient has good blood pressure and they're mentating well. That buys you precious time to grab a 12-lead ECG and call for an expert consult. But an unstable patient? They've got hypotension, an acutely altered mental status, signs of shock, or ischemic chest pain. Instability means you act immediately. No waiting around. Let's trace the pathway for symptomatic bradycardia, which is typically a heart rate under 50. First things first, oxygenate and assess stability. If they're unstable, boom, your first pharmacological move is atropine, 1 milligram, and you can repeat that up to a max of 3 milligrams. But what if the atropine doesn't work? You escalate. You immediately initiate transcutaneous pacing to mechanically take over the heart rate, or you can start a continuous infusion of dopamine or epinephrine to chemically drive the heart.
On the flip side, we've got tachycardia. If the patient has a rapid pulse and they are unstable, there is a golden rule you have to follow. They get synchronized electricity immediately. Synchronized cardioversion is your answer. Now, if they are stable, you've got time to check out the QRS complex. If it's narrow and regular, your go-to medication is adenosine. That's a rapid push of 6 milligrams followed by a 12 milligram dose if needed to try and chemically convert that rhythm.
Which brings us to Section 4, reversible causes, commonly known as the H's and T's.
Keep this in mind. You can run a mechanically flawless algorithm, but it won't save your patient if you completely miss the underlying physiological problem that stopped their heart in the first place. Let's break down the H causes. As a med student or young doc, you need to anchor these mnemonics into your brain for rapid recall. Is the patient bleeding out? That's hypovolemia. Are they starved of oxygen? Hypoxia. Think about acidosis, which means excess hydrogen ions. Check their potassium levels for hypo or hyperkalemia. Are they freezing? Hypothermia. And hey, while it's not officially an adult H, always consider hypoglycemia, especially in pediatric or diabetic cases. You have to actively run through this list in your head while compressions are happening.
Then we have the T causes. These are mostly mechanical, toxicological, or trauma-related. Tension pneumothorax, that's air trapping and collapsing a lung. Cardiac tamponade, fluid literally choking the heart's ability to beat. Toxins or overdoses, and thrombosis, which could be a massive pulmonary embolism in the lungs or a coronary thrombosis, which is a massive heart attack. Think about it. If you don't decompress that chest or push the right antidote, all the CPR in the world won't get you a pulse back.
All right, to finish building out your toolkit, let's dive into Section 5, Crucial 2025 Guideline Updates.
Medicine is always evolving, and the AHA has made some pretty definitive changes recently, so we're going to empower you with the absolute latest evidence. First up, vascular access. For a while there, intraosseous, or IO access, drilling directly into the bone was often treated as an equal first choice to an IV. Well, actually, scratch that. Not anymore. The 2025 guidelines officially state that IV access is the recommended first choice for giving drugs. Recent data actually shows lower rates of sustained return of spontaneous circulation when using IO compared to IV, so aim for the vein first. IO is now strictly your backup if those IV attempts fail.
Next up is a massive shift in how we time epinephrine for shockable rhythms. In the past, everyone rushed to push epi as fast as humanly possible, but the 2025 updates make it crystal clear. Rapid defibrillation takes total priority for VFib and pulseless VTech. You now intentionally delay epinephrine until your initial defibrillation attempts, usually after about 2 or 3 shocks, have proven unsuccessful. Simply put, electricity first, drugs second.
And this next update? It finally settles a debate that's been raging in resuscitation medicine for years. The AHA has definitively stated that vasopressin offers literally no advantage over epinephrine. None. So stop stocking it and stop asking for it during a code. Rely solely on epinephrine and just remove vasopressin from your cardiac arrest toolkit entirely.
Finally, let's talk about electricity and post-arrest care. If you're cardioverting atrial fibrillation, the new standard says go big. Start high with at least 200 joules. Lower energies just lead to higher failure rates, and nobody wants that. Once you do get a pulse back, what we call ROSC, your strict target mean arterial pressure, your MAP, needs to be a minimum of 65 millimeters of mercury to protect their brain. Oh, and one more thing. Despite all the marketing hype you might see online, head-up CPR is officially not recommended outside of clinical trials. Stick to flat, high-quality compressions for sure.
So there you have it. We've broken down the chaos. You know the basic mechanics, the specific algorithms for when the heart stops, races, or slows down. You know exactly how to hunt for those H's and T's, and you're armed with the absolute latest 2025 evidence. The next time those alarms blare and the monitor flatlines, you're not just going to stand there. You'll step onto the ward with this structured toolkit, ready to turn absolute chaos into life-saving order. So what do you say? Are you ready to lead your first code? Keep this explainer handy, review these algorithms often, and always trust your training. You've got this.